You know, when you walk into a hospital, there is this very specific sensory experience, right?
Oh, absolutely. It's a whole atmosphere.
Yeah, like you see the gleaming, freshly polished lobby floors, and you hear that rhythmic, sort of reassuring beeping of monitors in the background.
And you see the staff in their crisp scrubs just kind of moving with purpose.
Exactly. And as a patient or even a family member, you sit in that waiting room, you look around at all those visible signals, and you naturally think, okay, I am in good hands.
Right, because it is a deeply human instinct to judge the quality of something by its surface.
We really crave that visual reassurance, especially when we are feeling vulnerable.
We do. But the question is, how do we actually know?
Right. And that is exactly what we're getting into today. Welcome to a brand new deep dive where we are thrilled to have you, the listener, right here in the room with us.
We are stripping away the shiny lobbies and the comforting bedside manner today.
Yeah, we're looking at the invisible data architecture running behind the scenes. We've got this fascinating presentation by Dr. Abdallah Ibrahim.
Which is all about healthcare quality indicators.
Right. So our mission today is to demystify how the healthcare industry actually measures, good care.
Looking at the rigorous, often hidden metrics that define excellence in medicine.
So, okay, let's unpack this. When a medical facility claims to offer top-tier care, what numbers are they actually looking at to back that up?
Well, what's fascinating here is that true quality indicators are not just bureaucratic numbers.
Like they aren't just designed to fill up a spreadsheet so an administrator can sleep at night.
Exactly. They are vital guides for continuous improvement. The modern hospital tracks absolutely everything.
Everything from like the mundane day-to-day operations of a physical therapy clinic to massive critical sentinel events.
Right. And sentinel events, those are the really serious, unexpected incidents involving death or severe physical or psychological injury.
Wow. Okay. So these metrics effectively act as the central nervous system of healthcare quality.
They really do.
Which, sounds great on paper. Measure everything, improve everything.
But there is a catch.
Yeah, because before we even get into the specific things a hospital measures, we really need to understand how an organization decides what is actually worth measuring in the first place.
Right, because if you measure every single thing that moves in a building, you are essentially measuring nothing.
You just completely drown your staff in data.
And that is the ultimate trap of the modern information age. Healthcare is highly, highly susceptible to it.
So how do they avoid that?
Well, Dr. Ibrahim lays out a very deliberate, phased approach to avoid this data drowning. Phase I is entirely about educating the organization.
Because you can't just, drop a new tracking metric on a hospital staff and demand compliance, right?
Exactly. Mandates from a boardroom that make zero sense on the hospital floor, they're doomed to fail.
You have to actually involve the people who are executing the process.
Yeah, you have to understand the unique challenges of their specific services and actively solicit their feedback.
You have to get buy-in, otherwise people will just find a workaround to avoid the extra paperwork.
That's human nature. But once everyone is aligned, the presentation says you hit phase 2.
Okay, phase 2.
Which is identifying the critical few indicators.
I really love this concept. It makes me think of setting up a smart home system,
Oh, that's a good way to look at it.
Right, because if you program your phone to buzz for every single sensor, like a door opening, a temperature dropping 1 degree.
Or the dog walking into the kitchen.
Exactly. You'll eventually become so completely desensitized that you just ignore all of it.
You only want alerts for the critical few things that actually matter.
Right. Like, is the house on fire? Is the front window broken?
That analogy perfectly captures the danger of alarm fatigue, which is a very real phenomenon in hospital data management.
So how does an indicator qualify as one of these critical few?
It has to meet 5 strict criteria. First, it must be specific.
So you can't just say, we want to track infection rates.
Right, that's way too broad. It has to be, we are tracking central line-associated bloodstream infections in the adult ICU.
Got it. It totally eliminates the ambiguity.
Exactly. Second, it must be linked.
Meaning there's a clear cause and effect relationship to other performance goals.
Correct. And the third one from the presentation is that the data must be reliable.
I imagine that means it has to be scientifically and statistically sound.
Right.
Like, you aren't just going off gut feelings.
Yeah, or anecdotal evidence. But the fourth criterion is where things often fall apart in the real world.
Oh, really? What's that?
The data must be available.
Available. Okay, think about the implications of this.
Right. If an administrator creates a brilliantly specific, reliable metric,
But it requires floor nurses to spend 45 minutes manually digging through paper charts.
Yeah, entering data after a grueling 12-hour shift, that data won't actually be available.
It will be rushed, it'll be inaccurate, and the process will just breed massive resentment among the staff.
Exactly. The nurses will just pencil whip the form to get out the door and go home.
That makes complete sense. That ties right into the fifth criterion, right? It must be understandable.
Yes. When you put this data on a screen, everyone from the chief medical officer to the night shift custodian needs to instantly grasp what it means.
And why it actually matters.
Right. And once you have those 5 criteria locked in, you run them through the PDCA cycle.
PDCA. That's plan, do, check, adjust, right.
Exactly. You plan your data collection, you do the collecting, you check the results against your goals, and you adjust your practices.
Dr. Ibrahim emphasizes that measuring the right things allows you to build actionable performance reports.
You don't just stare at raw numbers on a grid. You use run charts to track how a metric changes over weeks or months.
And you use histograms to see the distribution of data.
Right. You are actively hunting for trends and opportunities for improvement.
All right, so we've set our trap for the data. We know how to pick our metrics strategically so we don't overwhelm the system.
Now we can actually look at what we are measuring.
Yes. To understand this, we really have to break healthcare down into its core components.
And the source material relies heavily on a famous framework in medicine for this.
The Donabedian model.
Yes, the Donabedian model. It separates care into distinct buckets so we can actually evaluate it.
And the logical starting point is the foundation, which the model calls structure.
Structure is elegant in its simplicity. It refers to all the underlying factors that affect the context in which care is delivered.
So we are talking about the physical facility itself, the medical equipment they own.
Right, the human resources and staffing ratios.
The financial resources backing the operation, and even the organizational characteristics like their official training programs.
Or their infection control policies.
It's basically the tangible stuff you can touch or read.
Yeah.
Like, does the hospital have a functional MRI machine?
Are the surgical nurses adequately licensed? Do they have a clear written policy for handling hazardous waste?
And because those structural elements are generally pretty easy to observe and count, these measures are incredibly common, aren't they?
Oh, very common. They are the primary metrics used for state licensure, for hospital certification, by accreditation bodies.
And by insurance companies to decide if a facility is legally up to par.
Exactly.
So what does this all mean for you, listening to this right now? It sounds a bit like judging a restaurant purely by whether it has a state-of-the-art convection oven.
That is a brilliant way to look at it.
Because the oven is great for the health inspector, and it proves the kitchen has the capacity to cook a meal.
But having an expensive oven doesn't guarantee the chef won't completely burn your food.
Right.
And you've isolated the exact limitation of structure measures. Having the capacity to do something does not mean that the function actually occurs.
Nor does it guarantee that the function improves patient health.
Dr. Ibrahim highlights a fantastic example of this disconnect. Imagine a hospital buys a cutting-edge electronic health record system.
Just to meet a structural requirement.
Right. So on paper, in the paper world, they check the box. They have the technology.
But in the actual world, the staff might find the new software incredibly clunky and confusing.
So they bypass it. They continue to print everything out and rely on paper records hidden on clipboards.
Or, like, a hospital might spend $10 million on that advanced diagnostic equipment you mentioned earlier.
But if the staff using it hasn't been properly trained, the structure is totally useless.
The capacity is sitting right there in the room, but the execution is entirely missing.
Structure provides just one piece of the full picture of care. It is the necessary stage setting, but it is not the play itself.
So if the shiny new MRI machine doesn't guarantee a good outcome, what does?
Well, we have to look at the human behavior surrounding that machine.
We have to look at how the doctors, nurses, and staff actually use their tools. Which brings us to the second category in the Donabedian model.
Process.
Process, okay.
Process is defined as the sum of all actions that make up healthcare.
So it includes the initial diagnosis, the investigation of symptoms, the treatment plan,
preventive care, and patient education. It is the actual day-to-day delivery of medicine.
And the presentation divides process into 2 parts, right? Technical processes and interpersonal processes.
Yes. Technical processes cover how the care is delivered medically. Interpersonal processes cover the manner in which that care is delivered by the staff.
A really clear example from the source material looks at diabetic patients.
Right. A process measure would ask, are the physicians ordering the necessary A1C blood tests?
Are they prescribing the correct insulin dosages?
And crucially, Are the nurses routinely examining the bare feet of diabetic patients during their checkups to look for hidden wounds?
Yeah, the clinical reason behind that last metric is vital. Diabetic neuropathy can cause patients to lose feeling in their extremities.
Meaning a tiny, unnoticed cut on the bottom of a foot can easily get infected.
Turn into an ulcer, and ultimately lead to amputation.
Checking the feet is a proven high-value action.
So from a data perspective, if you measure that specific process and find out it's only happening, say, 50% of the time.
You have an immediate, actionable piece of feedback. You don't have to guess what's wrong. You know exactly what behavior needs to be corrected.
Okay, but here's where it gets really interesting, though.
Oh.
If we are tracking every single action a medical professional takes, like, did they check the feet? Did they ask about this symptom? Did they prescribe that specific pill?
Are we just micromanaging them?
Yeah. Are we micromanaging them to the point where they're treating a checklist instead of a human being?
That is one of the most significant criticisms of relying solely on process measures. And Dr. Ibrahim's presentation totally validates this concern.
It seems incredibly easy to fall into the trap of checklist medicine.
Process measures are fantastic for managing chronic conditions and ensuring preventive care happens, but they are terrible at capturing the less tangible elements of quality.
Like appropriateness. A checklist might tell you that a surgeon successfully completed a spinal fusion.
But it doesn't tell you if that specific invasive surgery was actually the right choice for that unique patient's lifestyle.
Exactly. It also doesn't capture teamwork. A checked box doesn't reveal if the surgical team communicated effectively when a complication arose.
Or if the lead surgeon was just screaming at the nurses. There is a specific example in the source regarding smoking cessation that drives this home perfectly.
Oh yeah, the pamphlet example.
Right. Imagine a process measure that tracks the percentage of smokers who received smoking cessation advice during their clinic visit.
A hospital might score 100% on that metric. They look flawless on the spreadsheet.
But what did that interaction actually look like in the exam room?
Was it a doctor hurriedly tossing a generic pamphlet at the patient as they walked out the door with a dismissive, "You really need to quit"?
Or was it a genuine, empathetic conversation?
Did the doctor actually sit down and ask about the barriers the patient faces, their daily stress levels, and offer to connect them with a local support group?
A check mark on a chart treats both of those interactions as identical.
But if you are the patient sitting on that exam table, those are entirely different universes of care.
One is a bureaucratic exercise to satisfy a metric. The other is actual medicine.
The process metric tells us what the doctor did, but it completely lacks the nuance of how it was received.
And more importantly, it doesn't tell us if the intervention actually worked.
Right. Did the patient actually stop smoking? Did the diabetic patient's foot wound heal?
Process doesn't tell us if the patient got better. To figure that out, we need the results.
And that requires the third Donna-Beating category, outcome measures. This is where the rubber meets the road.
Outcomes are the ultimate goal of the entire enterprise. They are the most important indicators of quality.
Because improving patient health is the fundamental purpose of the healthcare system.
Exactly. An outcome measures the direct effects of healthcare on patients or populations.
So we are talking about concrete changes to health status, behavior, knowledge, and health-related quality of life.
The presentation uses a really memorable visual to categorize these outcomes called the 6 Ds.
Right. Death, disease, disability, discomfort, dissatisfaction, and destitution.
You are basically trying to minimize all those Ds.
Some are obvious, like minimizing death and disease. But how does a hospital actually measure something subjective, like discomfort or dissatisfaction at scale?
It requires a mix of objective and subjective data gathering. You measure the objective outcomes directly.
Like tracking hospital-acquired infection rates.
Or 30-day mortality rates, or whether a patient's hypertension is demonstrably controlled by their medication.
But for the subjective outcomes, you have to systematically survey the patients.
Right. You measure discomfort by tracking reported pain relief scores post-surgery.
You measure dissatisfaction through standardized questionnaires about their perceived level of knowledge regarding their own condition when they're discharged.
And destitution is a really fascinating one to include as a medical outcome.
Yeah, we usually think of financial ruin or medical bankruptcy as a billing issue, not a clinical outcome.
But if a treatment cures your disease but leaves you homeless, your overall health-related quality of life has still been destroyed.
It is a really profound acknowledgement of the holistic impact of care.
The source also gives some very stark binary examples of outcome targets.
Like hand hygiene compliance among staff. The target outcome is 100%, no exceptions.
or the number of accidental needle prick injuries to nurses. The target is exactly 0.
This all sounds perfectly logical. If I am a patient, I obviously care about the outcome. Did my cancer go into remission? Did my knee surgery actually relieve my pain?
Right.
But earlier, you mentioned that data has to be reliable to be useful.
Yes.
What if a doctor works in a severely underfunded community with a much sicker population? Do their outcome indicators look terrible just because their patients are harder to treat?
If we connect this to the bigger picture, you have just identified the absolute hardest part of outcome measurement.
It seems like a massive structural challenge.
It is. Let's look at a scenario. You are measuring the percentage of diabetic patients whose blood sugar is perfectly controlled.
Okay.
Dr. A works in an affluent suburb. Their patients can afford expensive organic food, have safe neighborhoods to exercise in, and experience relatively low daily stress.
Right. While Dr. B works in an inner-city clinic where patients live in food deserts, work 3 jobs to survive, and face constant systemic chronic stress.
Exactly. So if you just pull the raw outcome numbers, Dr. A looks like a medical genius.
And Dr. B looks completely incompetent.
And that is a dangerous, fundamentally flawed misinterpretation of the data.
So how do you fix it?
Dr. Ibrahim stresses that when developing outcome indicators, you absolutely must account for the social determinants of health.
You have to risk adjust the data for critical differences in patient populations.
You have to factor in whether a provider is dealing with patients who have multiple complex chronic conditions.
Or lack basic housing security. Because if we don't adjust for patient complexity, think about the perverse incentives we create.
Oh, it would be a disaster. We would accidentally incentivize doctors to avoid treating sick, complex patients just to protect their own quality scores.
We would end up punishing the very doctors who are doing the hardest work in the most vulnerable communities.
It creates a system where the sickest patients become liabilities to a hospital's data profile. Adjusting for these social determinants is a heavy lift. It requires extracting deep contextual data buried in medical records and analyzing it at scale.
But it is essential for fairness and accuracy.
Absolutely.
Okay, so we have the tools and the facility, which is structure. We have the specific actions the medical staff take, which is process.
And we have the medical results of those actions adjusting for reality, which is the outcome.
For a long time, that was the holy trinity of healthcare quality. But the presentation introduces a 4th category.
It does. It recognizes that a surgery can be a flawless technical success. The outcome is great.
But if the doctor never bothered to clearly explain the scary test results or treated the patient like an absolute inconvenience, the care was still fundamentally flawed.
You're talking about the human element, the newest frontier in healthcare metrics, patient experience.
Yes. Measuring if the care is truly patient-centered. The source specifically mentions the Abu Dhabi Patient Experience Model,
which emerged from a major patient safety congress.
This goes beyond just asking, did you survive the procedure? And asks, how are you treated as a human being while we were keeping you alive?
It's a vital distinction. Patient experience measures look directly at the interpersonal relationship with providers.
Was the information provided clear, accessible, and free of confusing medical jargon?
Did the doctor actually tell the patient about their test results in a way they could comprehend?
How long did the patient have to wait in a cold lobby before being seen?
Did a nurse proactively follow up after an X-ray to see how they were feeling?
You know, it's tempting to think of this as Yelp reviews for hospitals, but it's really more like evaluating a high-stakes airline flight.
Oh, how so?
Well, the outcome metric is simply that the plane landed safely. But if the cabin lost pressure, the pilot refused to communicate what was happening over the intercom, and the flight attendants were rude to you during the panic.
You wouldn't call it a successful flight, even though you technically survived.
Exactly.
That captures the gravity of it perfectly. And what's crucial to understand here is why this matters clinically.
It isn't just about making people feel warm and fuzzy for the sake of a hospital's public relations department.
No, there is a robust, well-documented relationship between positive patient experiences and actual clinical quality.
Wait, really? So a nice doctor actually makes you healthier?
In a very tangible way, yes. When patients have a positive experience, when they feel actively listened to, respected, and clearly informed.
They are significantly more engaged in their own care.
Exactly. They are more committed to following their complex treatment plans. They're far more receptive to medical advice.
Because if you trust your doctor because they treated you with empathy, You're much more likely to actually take the medication they prescribed.
And do the hard work of changing your lifestyle habits.
That makes total sense.
Hmm.
Like if the doctor who spent 5 rushing seconds with me tells me to completely change my diet, I might just ignore it out of spite.
Right. But if the doctor who sat down, looked you in the eye, and patiently answered all your questions tells you the same thing.
I'm going to the grocery store that afternoon to buy vegetables. The human connection facilitates the medical outcome.
However, because these patient experience measures are relatively new compared to the others, they do come with their own set of limitations.
Oh, sure.
Dr. Ibrahim points out that they aren't standardized or available in all healthcare facilities yet, and they need much more in-depth, rigorous study.
And you certainly can't just have a bunch of hospital administrators sitting in a conference room guessing what patients want.
Definitely not. The presentation explicitly notes that these metrics must be developed with actual patient input.
They have to accurately reflect the needs, the values, and the cultural preferences of the specific community being served.
Because what constitutes a good experience or respectful communication can vary wildly across different demographics.
So, to bring this all together, none of these indicators work in a vacuum.
Not at all.
If you only look at structure, you have a hospital with million-dollar machines, but potentially untrained doctors.
If you only look at process, you might have staff blindly following a checklist without caring about the human being in front of them.
If you only look at outcomes without context, you might unfairly punish doctors working in tough neighborhoods and incentivize them to avoid sick people.
And if you only look at patient experience, you might have a hospital where everyone is incredibly polite, but the surgical infection rates are through the roof.
Wow. That is the ultimate takeaway from Dr. Ibrahim's presentation, isn't it?
It is. True healthcare excellence requires deep integration.
You need the right tools, which is structure. You need the right actions, which is process.
You need the medical results, which is outcome. And you need the human connection, which is patient experience.
Only when you weave all 4 of those categories together do you get a true, accurate picture of quality management.
It really changes how you think about navigating the healthcare system, doesn't it?
It really does. The next time you, our listener, walk into a clinic or a hospital, you won't just be looking at the shiny floors or listening to the monitors.
You'll be thinking about the invisible data architecture running behind the scenes.
Tracking everything from the soap dispensers to the clinical outcomes.
It is a remarkable living system, constantly adjusting itself through that plan, do, check, adjust cycle.
Thank you so much for joining us on this deep dive into the hidden world of healthcare indicators.
We hope this framework gives you a new lens through which to view your own medical care,
empowering you to ask better questions the next time you're sitting in that exam room.
And before we go, I want to leave you with one final thought to mull over.
Oh, right.
We've established that what gets measured gets managed. We know how hospitals painstakingly gather this data right now.
Yeah.
But how might the explosion of wearable health technology shift these metrics in the near future?
Oh, wow.
Will your smartwatch be automatically reporting your patient experience, heart rate variability, and your outcome blood pressure data directly to your doctor's dashboard before you even leave the clinic parking lot?
Now that is a deep dive for another day. Thanks for listening, and we will catch you next time.